what I want to do is to put into context the current crisis in terms of what's happened to the NHS over the last 4 decades, in fact. I think it's also important not to misframe what we're currently seeing playing out as incompetence. Because if you understand the history of what's happened to the NHS, a lot of it fits in with intentional intention rather than accidental. And finally, I want people to understand by the end of my talk, what is the end game? Where is the government taking us to? And how might the cover of the COVID crisis actually help them with their agenda? So if we could have the first slide, please. So hopefully what you'll see now is a timeline of what's happened to the NHS over the last 4 decades, really. And what you see there is that, it didn't all start in 2010. We've had an uninterrupted trajectory of marketization, fragmentation, outsourcing, saddling with private finance initiative debt. And perhaps the biggest acceleration was in 2012 with the creation of a fully external market, that is forcing every activity of the NHS to be contracted out. And finally, in 2014, we had the 5-year forward view introduced by Simon Stevens, who was formerly of the American health insurance company United Health. The other things to point out while we've got this on is that in 2006, we saw significant changes to public health, and also around a year or two earlier around the GP and how general practice worked. So moving on from that timeline, how in what shape was the NHS? If you come back to me then, Peter. So what shape was the NHS in the run-up to the COVID crisis? Well, we'd had 10 years of austerity, relative defunding of the NHS, which led to we were 32,000 beds fewer than we were back in 2008. We had a recruitment and retention crisis with 40,000 nurse vacancies, 10,000 doctor vacancies, fewer beds. So we were in no shape to be taking on a pandemic. Not only that, in 2016, we had exercise sickness. Now, we knew a pandemic was not only a significant health challenge, but this was categorized as the #1 threat to national security. And what exercise sickness did was flagged up the deficiencies in our preparedness for a pandemic. Lack of protective equipment, lack of ventilators, and a desperate need to remedy these supply problems. But in 2006, we actually outsourced and privatized the NHS supply chain. In 2016, the government chose not to act on exercise sickness. They made a political decision not to prepare. So the political decision was prepare to fail, because pandemics occur. We know they're coming. So then we had coronavirus arriving on our shores. And although I was shocked by the lack of response of our government, I wasn't entirely surprised, because the NHS to them is not a public necessity. It's not about saving life. It's not about doing the best for the patient. It's a business for which it has to be restructured in order to maximize profit, and in order for that profit to be diverted to CEOs and to shareholders. Now, if a virus hits the country, which happens to affect the elderly and potentially the most expensive patients in a model that is designed to deliver profit. That is not incompatible. Having your most expensive and dependent patients succumb to a virus is entirely compatible with the business model of a privatized insurance-based system. So we had a narrative developed about staying home, protecting the NHS, and saving lives. But now we know that this strategy of avoiding testing, tracing, and isolating has led to us being at one point in late May having the highest death rate in the world. Now, this is a country that used to have a very robust public health system, the most developed in the Western world, with a long history of competence and excellence in dealing with infectious disease. But the Health and Social Care Act 2012 broke that apart. It dismantled public health systems and replaced it with a quango called Public Health England, where all the appointees are political appointments. And you have NHS England, which is in fact a privatisation board. And that's where the control has shifted. So the Secretary of State for Health is no longer responsible for the day-to-day running of the health service. That responsibility was transferred to Simon Stevens. And what it has led to is we had cuts to public health budgets of the order of 800 million. We had 10,000 redundancies in public health in this country. So you have an extraction of the organizational memory, the very skills you need in a pandemic were no longer there. So the situation was set up to inevitably lead to a very high death toll. Now, a government with a conscience who genuinely believed the strategy they were following of privatization would lead to better health outcomes, well, this should be a wake-up call for them that their policies have been wrong. And it was an opportunity to restore and reinforce the NHS and public systems. But what in fact happened, if we have the next slide up, Peter, what in fact happened is while we were all just being told to stay at home and wash our hands regularly, the government was very busy outsourcing as much of the pandemic handling activity as possible. So the slide we have on screen now is from the Financial Times, and we've seen 1.7 billion total contract value being awarded to private companies without any open competitive tendering process. So these backroom deals have been struck at enormous value, and we are still waiting for them to be functional. Whereas what the government could have done was to strengthen local public health infrastructure, was to use the now spare capacity within NHS hospitals and university labs to have a very robust testing system. And it could also use the huge capacity within general practice that was now freed up because we were no longer seeing routine care. You had GPs and my colleagues and myself, I've never had so much time on my hands. Yet this expert resource was deliberately bypassed. If you remove the slide for me. So you have this perverse situation where contracts are being given away hand over fist to the private sector. Meanwhile, spare capacity within the public sector, which we have already paid for, wasn't used. And where did some of the money go? Well, if you look at the connections to where some of the contracts went, well, some of the IT contracts went to people connected with the Vote Leave campaign and with personal and professional connections to Dominic Cummings. A company called Faculty AI is one that springs to mind. Another company that has now got access to the pandemic data is Palantir, run by an American billionaire, Peter Thiel, who has close associations with the CIA and the Donald Trump campaign. One of the co-founders of Faculty is a person called Mark Warner, brother of somebody who's been brought in by government as an advisor. So, alarm bells about due process, conflicts of interest, appropriateness of awarding contracts. In the height of a pandemic, they chose to reinforce and double down all the methods that have led us into this precarious situation. If we bring up slide number 4, this is from The Guardian, which shows, if you have an infectious disease pandemic, who do you put in charge? An accountancy firm. How does that make any sense, to award this responsibility to an accountancy firm, to involve private pharmaceutical companies who have got no experience in testing, to set up a series of standalone labs staffed by people without adequate training and without due regulatory oversight? That's what the government has created, rather than using existing capacity. So if we remove that again, is any of this an accident? Well, if you just consider what's happened to general practice in the last decade, you've had the outsourcing of out-of-hours care, you've had the introduction of 111, you've had more recently the introduction of a new GP contract, which will in due course, and if you put the last slide on, I'll show you what I mean. The new GP contract will introduce perverse incentives for the GP to boost their income by denying patients care. The slide on the left is from United Health, which talks about a shared savings program right at the bottom on the left. The slide on the right is from the NHS long-term plan document, which refers to a shared savings scheme. So these are perverse incentives for GPs to deny you care. Now that's if you're lucky enough to see a GP face-to-face. Face-to-face contact with a patient is considered as a legacy system to be minimized. And the reason for that is because you can make a lot more money by digitalizing services and removing the people with the experience and perhaps the training and the ethical obligation to act as advocates for their patients. So that brings us up to the current situation and the threats for people to look out for in terms of the policy forum is the traps that are being set. We are being trapped into accepting that the integration of means-tested social services budgets with health budgets is a good idea. No, it isn't, because that's a backdoor way of bringing in means testing. We are also being softened up for personal health budgets. They are a device to entice very expensive patients away from requiring insurance until such time as there's been a significant middle class shift into top-up insurance, at which point they will be unceremoniously dumped and left without care. So personal health budgets is another trap that is just on the horizon. And finally, the longer term consequence of COVID is the massively expanding waiting list, which we will be softened up into accepting this is yet another reason for using private sector capacity. And the middle class will be persuaded to look after themselves and take out private insurance. All of this overseen by the former president for global expansion of United Health. Thank you.